Good morning, and thank you for joining us for today's Virtual Investor Innovations in Oncology Spotlight Series featuring AIM ImmunoTech. My name is Janine Thomas, CEO of JTCIR, and I will be the moderator of today's event. So happy to have everyone join us for this series, and we're excited to get started. I'm pleased to be joined by Thomas Equels, Chief Executive Officer, Dr. Chris McClear, Deputy Chief Science Officer of AIM ImmunoTech, and Professor Casper Van Eyck, PhD of Erasmus MC. So happy to have you join us. I would like to remind our audience that AIM ImmunoTech is publicly listed on the New York Stock Exchange and trades under the ticker AIM. During today's discussion, the company will be making forward-looking statements, and we encourage everyone to view the company's latest SEC filings on their website at aimimmuno.com for the latest information. Welcome, gentlemen.
Welcome.
So happy to have you. So before we get into today's discussion, Tom, can you please provide an overview of AIM ImmunoTech for those that are new to the company?
Well, thank you, Janine. AIM ImmunoTech is a immunology research and development company, and we're developing our principal investigative drug, Ampligen, as a therapeutic in oncology, especially certain highly lethal malignancies for which there are total unmet medical needs, and as an antiviral and as a drug to help with an immune disorder known as chronic fatigue syndrome, which is also an area that we're working in that's related on what's called long COVID. The fatigue and brain fog and certain of the symptoms of long COVID are very, very similar to chronic fatigue syndrome. But principally, and as a priority, our work right now in oncology is the most important thing to us and the most important thing to our long-term development.
Wonderful. Appreciate that, Tom. So Dr. McClear, first I want to congratulate you as recently joining the AIM team. Can you provide us with your background and your field of expertise?
Thank you, Janine. I always hate talking about myself, but I am happy to be here at AIM. My collegiate experience is in the world of biology and chemistry with a master's degree in molecular microbiology and a PhD in biomedical sciences. After graduate school, I helped build a preclinical CRO focused on designing and creating microphysiological devices for a wide range of human conditions and diseases. My doctoral training was mostly as a muscular and neuromuscular biologist, but I have done cancer research in collaboration with Roche that was published in Translational Medicine and featured by at the time the NIH director Francis Collins' blog, which I thought was a unique experience for me. I've done work in innate immunity also with Roche. It's published in Science, drug metabolism and pharmacokinetics and its relation to pharmacodynamic parameters such as cardiac toxicity and with AstraZeneca. And we've built cellular and tissue models of rare diseases with Sanofi and Apellis. And those are good. I'll stop there. Those are some of the highlights of the work that I've done. And I'm sure you can tell, much like the broad spectrum activity of Ampligen, I have a broad spectrum background that I hope will help catapult AIM to the next level. I'm happy to be here. Thanks for having me.
Wonderful. Thank you. And that's great for the setup for our discussion for today. So appreciate you providing that background. So now over to you, Professor Van Eyck. We truly appreciate your participation in today's event and your time. Can you, from your perspective and expertise, you bring so much value to this company. Can you provide an overview of your background and your area of focus?
Thank you, Janine. Yeah, it's my pleasure to be here. I'm a pancreatic cancer surgeon for more than 25 years in Erasmus Medical Center in Rotterdam, which is located in the Netherlands. It's one of the largest university hospitals actually in Europe. And since I'm working with pancreatic cancer and run several clinical trials, I especially came interested in what is called the immune maintenance therapy for pancreatic cancer patients, which actually means that after the standard of care, a lot of patients actually in the Netherlands want to have what is called maintenance therapy because they don't want to wait for their recurrence, etc., etc. And then I really got interested in what Ampligen actually could offer to those patients. And I contacted Tom actually in order to see whether we could set up what is called a compassionate use program in the Netherlands. And that's what actually we achieved 5 years ago. And I'm really very pleased for the patients, especially that we could provide them some therapy, and some patients really benefited of that program.
If I might add something, Janine, Professor Dr. Van Eyck is really considered one of the world's preeminent pancreatic cancer oncologists and researchers, and it's been a great honor to work with him and to visit Erasmus on numerous occasions and watch the amazing things that he does to help late-stage pancreatic cancer patients have a better life.
Appreciate that, Tom. And as I said, Professor Van Eyck, we are so thrilled to have you join us today. And I think all of those backgrounds, the overview, Tom, that you provided, and the backgrounds from Dr. McClear and Professor Van Eyck really set up the stage. And now I'm ready to dive into the company's lead asset, Ampligen, which is currently being developed for a number of globally important cancers, viral diseases, and disorders of the immune system. Tom, could you please provide an overview for our audience of Ampligen?
Certainly. Ampligen is a toll-like receptor 3 agonist. And what that means is that it has an impact activating one of the primary pathways of the human immune system. And this is why in these various studies that we've conducted over the past several years, we see an impact of Ampligen not just in oncology, but as an antiviral and as an immune system modulator, because it's working at the base of the immune system to activate the innate immune system and a number of other functions, which Dr. McAleer and Dr. Van Eyck will discuss, I'm sure. But because of that, and because we've administered, for example, intravenously, about 100,000 doses in humans, and it's been generally well tolerated. We have also demonstrated to the satisfaction of agencies to allow us to go forward with clinical trials, intraperitoneal safety for ovarian cancer. That's where Ampligen is injected into the peritoneal cavity. We've demonstrated intranasal safety, with it being generally well tolerated in a study done at Leiden University in humans to get a safety profile with intranasal Ampligen, especially for antiviral uses. So we have a drug that's very safe, very well tolerated, often improving the quality of life for subjects with dread diseases. And we are focused principally right now on these lead cancers that we're working on. Ampligen is a sole agent in pancreatic cancer. And then we're going to be looking at Ampligen in pancreatic cancer when we get a chance as a combinational therapy with certain checkpoint blockade drugs. We also have tremendous data coming out in advanced recurrent ovarian cancer in the Merck grant funded phase 2 that's going on right now in Pittsburgh. Ampligen, cisplatin, and Keytruda. And those interim results, which were spectacular, those data clearly suggest a major therapeutic impact when you add Ampligen to that mix.
Appreciate that, Tom. And the opportunity with Ampligen is truly incredible. So Dr. McClear, with Ampligen's broad utility across a number of disease classes, it would be good to understand its mechanism of action. Can you please tell the audience about the mechanism and how Ampligen can be utilized as broadly as it is?
Sure. I'll try not to go too deep into the heavy science. I don't want to bore everybody. And Tom gave a pretty good overview there. And I'll try and condense it down to the simplest version that I can. Simply stated, Ampligen is a selective toll-like receptor 3 agonist, and or an activator of toll-like receptor 3. And toll-like receptors are part of the innate immune cascade, and different receptors recognize different pathogens. And for this, toll-like receptor 3 can be found on or within endo and epithelial cells and immune cells, so dendritic T cells, B cells, macrophages, monocytes. And it's really unique among all the toll-like receptors because it's independent of the MyD88 pathway. So a lot of times when you get immune upregulation, you get a huge cytokine storm and this cascade that causes off-target effects, right? The toll-like receptor 3 are selectively activate type 1 interferons in the interferon cascade. And that's simple and complicated all at the same time, isn't that there are quite a few interferon, upregulated genes, that ISGs that get activated from interferon. And so with all that being said, it blocks viral replication and it modulates the immune functionality. And so like in the case of colorectal cancer, metastatic to liver, it's been shown to downregulate Treg cells while also upregulating CD8 positive T cells. Essentially, that converts the tumor microenvironment from like a safe haven for cancer cells to a really hostile environment, right? And so activating the innate immune cells that are there in the tumor microenvironment to attack the tumor cells. And so, as I'm sure Dr. Van Eyck will discuss, in long-term survivors, the data suggest it lowers the systemic inflammation index and lowers the lymphocyte to neutrophil ratio and upregulates the B cell population through its immune modulating functionality. And so, and that's just some of the oncology data, and Tom has pointed to some of the other studies that we're currently doing. I know I said I was going to make this short, and maybe that wasn't exactly the short answer you were looking for, but it has a few synergistically harmonious modes of action via the antiviral cascade and the immune cell modulation through toll-like receptor 3 that provided its broad spectrum functionality.
As Dr. Van Eyck will confer, it turns cold tumors into hot tumors. That's a short version.
Yeah, so I hope that answered your question.
No,
Yeah.
Going too far and boring everybody.
No.
No, you didn't, and that was riveting to say the least. No, it was very, very helpful. And as we go further into today's session, we're going to touch on a lot of that. So, Tom, when you talked about Ampligen, it is clear that your clinical oncology pipeline is extensive with multiple ongoing clinical studies across a number of indications. Can you please highlight your pipeline for the audience? And are there any ongoing studies that you'd like to call out to investors that they should pay close attention to?
Well, certainly. The study we're talking about today is near and dear to me for a number of reasons. Upon becoming CEO, we repurposed at that time Ampligen into oncology. And our first venture in oncology was in conjunction with Professor Dr. Van Eyck and Erasmus Medical Center in pancreatic cancer. And getting the Dutch government's authorization was very important. We were dealing with extremely late stage patients who had very few prospects for improved quality of life or extension of life. And Dr. Van Eyck, I think, made me a true believer. And I may have helped him at times too, because when you're starting something like this and you don't really know what's going to happen. But our faith in Ampligen and the idea has been more than proven out by the interim data to date. And I am extremely grateful for the commitment of Dr. Van Eyck and his team at Erasmus in helping us to bring what may be a new standard of care as the data develops, that it extends the life of late stage pancreatic cancer patients, not just by days, not just by weeks, but by a significant period of time, utilizing this as a maintenance therapy. And that's our top priority right now.
Okay, well, that's a great segue, because I know today we are going to focus on your pancreatic cancer program. Kind of to set it up, though, for our audience, Professor Van Eyck, can you please speak to the current unmet need in pancreatic cancer? How many people are affected? What treatment options are available? And what is the outlook for a patient who receives this terrible diagnosis? Also, how would you define maintenance therapy for pancreatic cancer patients? I know that was a lot in one question, but would love to get your insight on this.
Okay, well, I can give you some numbers which, in my opinion, are extremely important. First of all, you see that still pancreatic cancer, the incidence is increasing. And actually, in about 2 or 3 years' time, it will be the second cause of cancer death all over the world. So that means after lung cancer, pancreatic cancer will be the second cause of death. And for instance, in the Netherlands, there are about 3,500. And I think in the United States, it's about 60,000 people annually, who are diagnosed with pancreatic cancer. And actually, the outcome of pancreatic cancer patients in general is about 3 months' time after the diagnosis. So that's really a very terrible disease, and that's caused, I think, most because of its biological behavior, which is very particular and is different from other type of cancers. And what we've found in our previous work was that the immune suppression actually, which is present in patients with pancreatic cancer, is really extreme. And that also brought us to the idea that maybe, we can do and help the patients by changing that and helping the immune system to attack the pancreatic cancers. So that's really what was the first idea. And what we have as a standard of treatment actually in the Netherlands, and I think that's a bit different than in the United States, is that in those patients who, what we call our WHO 0 to 2, we start with FOLFIRINOX, which actually is a combination of chemotherapeutics, which is effective, and in about 60 to 80% of patients, it stabilizes disease. But on the other hand, you should consider that that treatment actually is very toxic, because you see a grade 3 to 4 toxicity in those patients in about 60% of patients. And then actually after stopping the treatment, which normally consists of about 8 to 12 cycles, that depends how the bone marrow, etc., is reacting to that treatment, then the prognosis of the patients is about 4 to 6 months more. So a lot of patients actually in the Netherlands, they really do wonder whether it's worthwhile to have, such a toxic treatment for 3 months, which actually only add 3 more months. And that means that what I said already in the introduction, that a lot of patients after stopping the FOLFIRINOX really think that there should be something add to it, because, and that's what we call maintenance therapy. They're not going to sit and wait when the recurrence, when the progression actually starts. So they really looked forward to have something as a maintenance therapy. So that's why we actually thought, and the first idea in doing that was with Amgen. So that's actually really scheduled with the whole problem of pancreatic cancer.
And perhaps Casper, you could discuss the initial data from the first study and the remarkable impact on survival that was observed, as well as quality of life.
Yeah, I mean, in the first, so talking about the clinical trial, we first, it wasn't actually a trial, but it was just what I mentioned before. It was on a treatment compassion use base, and it was part of an immune profiling program. So that means that all the patients who entered our clinic were what we called profiled immunologically. So that means before the start of any treatment, either operation, radiotherapy, or FOLFIRINOX, there was an immune monitoring done using nanostring technology. And what we actually saw in the first 30 patients was that there was an improvement in 2-year survival of about 30 to 40% of the patients. So that was really amazing. But it was, in our opinion, very important also to select and to find out which patient would benefit and which patient would benefit. And then actually it turned out that the patients whose immune system was affected extremely by the pancreatic cancer, which was actually measured by defining the SII, which actually is nothing else than the systemic information immune index. And we thought that the patients whose immune system was decreased extremely by the presence of the pancreatic cancer actually were not helped by the treatment of Amgen. But the patients who actually still had, some function of the immune system, they really did extremely well. And what we didn't measure, but what we are measuring now in the second trial, is that also it was very considerable, the quality of life of the patients who were treated. There wasn't any adverse side effects. There wasn't any patient, brought to the clinic because of any complications. So that actually is something which is extremely important for those patients with at the end of their life, due to an unresectable cancer. So that really were all kind of things which were very promising. And as Chris already mentioned, what we also thought that in the patients who did well, you see a huge increase in the B cell population, which might be extremely important also for cancer survivors in general. So, I mean, we were very glad, and therefore we considered also to start up the second program using the patients who had a normal or who had an SII below 900, which is considered having a good immune system. Sorry. And also patients who had the CA99 was lower than 1000. And those patients are doing extremely well. We will bring out those numbers in a few months' time.
Wonderful. Appreciate that insight. And I know that we are going to transition further into the clinical development of Ampligen for pancreatic cancer. But you've described, both you and Tom, Dr. Van Eyck, have described there is definitely an enormous need for the development of a new therapeutic solution for pancreatic cancer patients. So, Dr. Van Eyck, what about Ampligen gives you confidence it will ultimately be successful when there have been so many failures in pancreatic cancer development?
Now, as I mentioned before, I first think that it's extremely important to select the patient as well. So, and that's nearly in all kind of, or in a lot of cancer types, it's extremely important to identify patients who might benefit from therapy or not. So that's, in my opinion, is extremely important. And I think we really are very nearby to do so. That's the first thing. And another thing is that maybe the Ampligen is the first step. And combining Ampligen with immune checkpoint inhibition might also be extremely interesting in certain kind of patients. So that's one thing. And the other thing which we didn't mention yet is, but that's also a program we are running, and we are nearly publishing also a paper on that, is that certain pancreatic cancers itself, so not the immune cells of the cancer, but the epithelial cancer cells themselves also do express toll-like-3 receptors. And what we found in that those were all in vitro experiments, but on those epithelial cancer cells expressing toll-like receptor, they were extremely sensitive to the Ampligen treatment. So it might also be the case that there is a rule of Ampligen in all cancer patients expressing toll-like-3 receptors. But of course, those data needs to be confirmed in clinical studies, etc., etc. But we should all be aware of the fact that also Ampligen might have a direct effect on the toll-like-3 receptor epithelial cancer cells.
I just want to point out there was a poster published and presented in New York by the team, Casper Van Eyck's team at Erasmus, with data related to this point. And it only makes sense. Ampligen is a toll-like-3 receptor agonist or activator. So one doesn't have to go far to make the logical connection that tumors expressing toll-like-3 receptors might be more prone to a positive response to the Ampligen.
Okay, appreciate that additional input, Tom. So the Dutch government has approved an early access program in partnership between AIM and Erasmus University. Professor Van Eyck, I believe you've touched on some of this, but can you just tell our audience about this program in detail and the additional translational research?
Yeah, well, so what I mentioned, it was a compassionate use basis. It was part of an immune profiling program, what we actually did. So what we needed to do is to ask the Dutch government in order to approve that we were using Ampligen in order to treat and monitor the patients. So as I mentioned, the patients were at an outpatient clinic twice a week. They received the Ampligen, and we measured, before the 6 weeks treatment of Ampligen, we measured the immune profiling, and also 6 weeks after. And that means that we continue doing so for more than a year. As I mentioned before, in the first program, we didn't measure the quality of life, which we consider now as a mistake, but we should have done that, and therefore we incorporated that in the next trial we are actually running. And also those data are nearly available, where we also measure the quality of life, which in my opinion improved a lot if you look at the data after the treatment of those patients with Ampligen. But again, I would state that it's very important to select your patients who might benefit from Ampligen, but because not all of the patients, especially not the patients at the end, at really end-stage disease, will benefit of Ampligen. And also consider the fact that it might be the first step in a combination of immunotherapeutics. But since there are no side effects on it, I mean, it's extremely useful for the cancer patients.
Incredible. Can we talk about the new data you have generated to date?
Yeah, of course, I'm glad to also to share that. But this is actually what you see. So this is cohort 1 and 2, which actually means that it's a much more homogeneous group. So that means that the patients all have only FOLFIRINOX as the initial treatment. So that's extremely important to measure, to mention. And what we did, we compared that with historical controls who also had FOLFIRINOX and also were in a very good clinical condition. And what you see is that you really delay the progression-free survival, but what, in my opinion, is much more important to see, and that's also something we have discovered. Can we have the next slide? So this is the overall survival. And what this actually tells you is that after having a progression, what you saw on the previous slide, by starting again, either the FOLFIRINOX or another combination of treatment is much, much more effective. So that's translated in this overall survival curve. So what you see is that, what we call the median survival actually is going up to about 30 months from 8 months. So that means that 50% of the patients do live more than 20 months longer only by having been treated 6 weeks by Ampligen. So I think those are amazing results. And of course, we will make this group better. And the next step, of course, needs to be a randomized controlled clinical trial, etc., etc. But at least from my opinion, especially remember that we are dealing with one of the most aggressive cancers, and where there were so extremely trials being done with a lot of very toxic agents, phase 1, phase 2 studies coming from the pharmacy, where you didn't see any improvement at all, that these results really look very promising. So I'm really impressed by it, and again stated that this might or could be the first step, because combining Ampligen with checkpoint inhibition or some other drugs might even further improve this kind of treatment.
Excellent, excellent. I really appreciate you walking through that. It's so amazing for patients, especially those that get that terrible diagnosis, their families, and especially important for the scientific community. Congratulations on those amazing results. And I know that we are moving forward with clinical development. So I'd now like to turn to the upcoming clinical advancement of Ampligen for the treatment of pancreatic cancer. So Tom, you announced your IND cleared and that you will be initiating a phase 2 study in locally advanced pancreatic adenocarcinoma this quarter. Can you please provide an overview of the study design?
Certainly. This will be a multi-site study with the principal sites being at Erasmus MC in Europe and Buffett Cancer Center in the United States, but with additional sites as needed to bring in subjects rapidly. The IND has recently been authorized, and we're trying to expedite the commencement of the study now that we have FDA authorization to commence the study. And we're doing everything humanly possible to try and get it up and running this quarter, by the end of this quarter. Certainly, we have every hope that if we don't have control over all of these things in terms of sites and everything. So there may be some hiccups and delays, but everything's on track so far. The actual trial is very similar to the work done at Erasmus, in that we're taking fulfurinox treated subjects in locally advanced pancreatic cancer, and 4 to 12 weeks after the completion of the fulfurinox treatment, if they are stable, if they haven't progressed, then there will be a randomized selection of subjects on a 2-to-1 ratio, ultimately with 60 subjects receiving Ampligen as a single agent therapy twice a week, compared to the standard of care, which in locally advanced is no treatment until progression. And we'll be measuring progression-free survival and overall survival. And the data, which is fairly significant, that we have from Erasmus in the Compassionate Care Early Access Program, which is ongoing, but was the basis for the first study, and in the Dutch authorization of that, will I believe suggest an incredible opportunity to demonstrate with randomized controls instead of historical controls this same effect. Now, the only major difference between the phase 2 study that we are commencing and the work that was previously done in the Netherlands is that from a maintenance therapy standpoint, we will continue to administer Ampligen, not for just a short period of time, but for a longer period of time, until either the investigator, the clinician, suggests otherwise, or that individual progresses. So there'll be a somewhat longer period of Ampligen therapy, which we hope will indicate an increased level of improvement for those people that are on this maintenance therapy. Dr. Van Eyck, you're more familiar with the actual protocol than I, and the design of it. Could you comment on that, please? I think you're on mute. Dr.
You're
Van
still
Eyck.
on mute.
Tom, as a lawyer, you did an amazing good job explaining a clinical trial. That's true, but no, in fact, this is the way it works. I mean, I think that should be mentioned is that it's extremely important in those clinical oncological trials to have the group as homogeneous as possible. So that's the explanation why for this trial we used the locally advanced patients, because you can also consider to include metastatic patients, but just for the homogeneity of the group to treat and not to treat, I mean, therefore we actually choose the locally advanced patient. And on the other hand, by telling you that about 30 to 40% of all pancreatic cancer patients diagnosed are actually only locally advanced. So it's about 5 to 10% is being considered resectable, 30 to 40% metastatic, and 30 to 40% are locally advanced. So the group is very big. So we have more than enough patients in a very short period of time. So that's also important to mention.
It's also important to mention that Dr. Van Eyck mentions, the comparison value of locally advanced. In other words, we're comparing apples to apples with metastatic cancer, especially in the United States. There are a number of different drugs that are a part of a multifaceted standard of care. So it doesn't allow us to do a direct comparison the same way we can do in locally advanced. But I want to point out, and perhaps Casper, you can comment on this, the data that was derived from the initial study and the continuing data shows and suggests a very powerful therapeutic impact in metastatic as well. We're not avoiding metastatic because of a problem with what the data suggests and the signal. It's principally to get a good, clean statistical comparison.
Yeah, that's right. Therefore, we continue also our expansion of the second, what we call the second cohort, including also metastatic patients. But it will be much more difficult, to have a good clinical trial with metastatic patients than have a clinical trial with locally advanced, just of the reason. Because to make things clear is that after the initial treatment of FOLFIRINOX, that's the only treatment option actually in the Netherlands, because the insurance companies don't pay for anything else, because that's not actually proven to help. But in the United States, after having the FOLFIRINOX, you get another treatment and another treatment, although it's not really evidence-based, but that's completely different than in the Netherlands. But the treatment option in the United States for actually only for locally advanced is also FOLFIRINOX, and then in some centers they add radiotherapy to it, but most of them give only FOLFIRINOX. So therefore, making this trial possible as a maintenance therapy is much more feasible in locally advanced than in locally advanced and metastatic disease.
And we're very excited about this opportunity because, when you have such a strong signal in the work that has been done at Erasmus Medical Center with Dr. Van Eyck and his team, it makes it not just feasible, but compelling that we get this study started, because this is an opportunity for us to change lives and save lives in a lethal malignancy where today there really is no hope.
I really appreciate that. So Dr. McClear, is based on the data, I know both Tom and Professor Van Eyck talked about the focus on locally advanced pancreatic cancer. Is there anything you'd like to add to the rationale for why you're focusing on that for the next program?
Yeah, I mean, I think that Dr. Van Eyck and Tom have done a pretty good job. Simply stated, we focused on the locally advanced because, it's a scientifically driven business decision, right? So if you look at that data, the metastatic data looks very, very promising. There is also a subset of that data that is locally advanced that is also very promising. And I would venture to I'm always hesitant to speculate, but if you wanted to speculate, taking that group of 5 patients out to something like 30 or 40, 60 patients, right? That data, I would, if it holds to repeating, from those 5 patients, would be really significant, right? And so the problem is that the standard of care differs around the world between the Netherlands and the US. And if we want to move some of these clinical studies into the US, we have to take that into account. And the standard of care for metastatic cancer differs widely in the US, right? You either take FOLFIRINOX or gemcitabine with paclitaxel, right, for your primary therapy, and then you'll do a maintenance therapy that can range all over from FOLFIRI to 5-FU to leucovorin, oxaliplatin, gemcitabine, radiotherapy, and combinations of any of those drugs, right? And so things may work differently in the Netherlands, but in the US, the FDA precludes any of the investigators from limiting any of the standards of care in their investigatory studies, right? And so therefore, if we were to add Ampligen to this, we'd have to also take into account all those individual standards of care in the maintenance therapy for metastatic patients, right? And that lowers the number of individuals that are in any one of the individual cohorts. And so while I believe that, the individual patients would benefit greatly from having Ampligen in metastatic cancer, it would have very limited to no value to AIM in and of itself, right? But if we look at the locally advanced pancreatic cancer, and Dr. Van Eyck pointed to this, there is a greater homogeneity of the individual cancer patients themselves, right, as opposed to the metastatic, in its nature of the variability of how it metastasizes, right? There also is a simple standard of care after FOLFIRINOX or gemcitabine paclitaxel, right, which is essentially nothing, right? You wait until there's progression that occurs, right? And so that provides us a very unique opportunity to add Ampligen as a maintenance therapy, not competing with any of the standards of care that already exist in the metastatic cancer patients, to look at that. And if you look at that preliminary data from Dr. Van Eyck's team, I think there's a very unique opportunity to make a very, I don't want to call it streamlined, but very focused study in cancer, in pancreatic cancer patients using the locally advanced. What we can do after that data comes in a controlled study in the way that it's designed in multi-centers, including Dr. Van Eyck's, will help us to then figure out how we want to move forward next and talk to the FDA about transitioning that perhaps into metastatic cancer. But we need to get that data first, right? And so simply stated, it's a very controlled, very organized, very scientifically driven business decision.
Perfect. So, Dr. Van Eyck, we've talked about a lot of different topics, just leading up to my next question. But I know you covered part of this in a couple of your answers, but I just, for our audience, wanted to kind of have a direct question. So I'd love to hear your thoughts on the design of this upcoming phase 2 study. How does it compare to other pancreatic studies? And what is the rationale for dosing Ampligen following treatment with FOLFIRINOX?
As I mentioned before, there are a lot of studies comparing actually FOLFIRINOX with other drugs. There were a lot of studies comparing FOLFIRINOX with a lot of other drugs in patients with locally advanced pancreatic cancer. But then it turned out, that actually the standard of care is FOLFIRINOX. But what we actually try to do is to see whether using Ampligen we actually can stabilize the disease and delay the progression, because all those patients with locally advanced metastatic locally advanced pancreatic cancer finally die of metastatic disease. So that's something what we try to delay with the Ampligen treatment. And again, to point out, it's important to have a homogeneous group. And if you look at the literature, normally the locally advanced pancreatic cancer patients are very homogeneous because there are some special tumor characteristics of locally advanced cancers which actually are different from metastatic disease. And all those points, as Chris also mentioned before, make our decision to do this study in only patients with locally advanced. And we need to compare it because the standard of care in those patients, as I mentioned, after FOLFIRINOX, there isn't any evidence-based maintenance therapy. So, I mean, you can give patients therapy, but the insurance companies, at least in the Netherlands, they don't allow medical oncologists to give them any medication as maintenance therapy because there is no evidence-based maintenance therapy. And since Tom and his team provide us, let's say, the Ampligen, I mean, we can do those studies since we have a very good immune profiling program, and we can learn a lot from those patients, because I still believe that whenever you do a study with new medication, you should not only do what is called a scientific clinical study, but also look at which patient finally will benefit from that treatment and who won't. And that's what we're actually monitoring in this study as well, which in my, again, is a very important point. Because not all patients will benefit, but if 60 to 70% of the patients will benefit, it will make a huge impact. Because as I mentioned before, nowadays, it's the second cause of cancer deaths all over the world.
Well, and just as a follow-up to that, the immunological studies that are on a parallel track and a part of what we're doing in the Netherlands, give us some prognostic ability to determine, as Dr. Van Eyck says, who will respond to the Ampligen. So if we're getting generally, let's say, a 50% increase in overall survival and progression-free survival, but we're able to identify that those who express toll-like 3 receptors in their pancreatic tumor will have a heightened chance, well, then obviously that selection criteria steadily increases the therapeutic impact for those people who are selected.
So this discussion so far has been so helpful. We've talked about the desperate need in pancreatic cancer patients. We've talked about Ampligen, the mechanism of action, prior data, the upcoming study. So why don't we move to what's next? So Tom, assuming the phase 2 study is successful, what do you see as next steps for the program?
Well, as I mentioned at the beginning, we're an immunology research and development company. We're not a big pharma company. We're not Merck or AstraZeneca or Pfizer, even though I have my Pfizer tie on today. But we're in the business of developing this drug for an important unmet medical need in oncology. Now, as we move forward into this randomized control clinical trial, if we're able to demonstrate data similar to or better than perhaps the data that we've seen in the historical control study conducted in the Dutch Early Access Program by Dr. Van Eyck and Erasmus, then whether it's in interim results or the final results, if we're able to publish those results, I believe we then will attract the attention of big pharma and create licensing opportunities, which now go to the commercial part of this, so that the drug can finish its development in the hands of a large pharma company that has the resources to do all that needs to be done and has the marketing and manufacturing and distribution capacity. But as anyone who studies this space knows from a commercial standpoint, those transitions from the immunological R&D company to big pharma for licensing often present great long-term opportunities for the investors. So that's our goal commercially.
Yeah, absolutely, and very, very exciting. And it sounds like you're well on your way to having something like that come to fruition.
And Janine, if I might add a point, sometimes in life, the only thing people think about is money. And obviously there's a tremendous potential for a positive commercial transition here in pancreatic cancer alone, which, as Dr. Van Eyck pointed out, is soon to be the second largest lethal malignancy on Earth. But, more importantly, is that in this particular instance, we're moving into a place where this preliminary data strongly suggests that we have an opportunity to extend lives and save lives that otherwise would have a very short and a very poor quality of life in front of them. So we're extending not just hope, but a real opportunity for change in that particular space. Dr. Van Eyck, if you could comment on that, I'd appreciate it, because you know more than anybody. I know you counseled me one time when I was meeting with the subjects at Erasmus, and one of them was talking about how good she felt. You pulled me aside and said, Tom, what's remarkable about this is pancreatic cancer patients, late stage pancreatic cancer patients, never tell me they feel good. Do you remember that, Casper?
Yeah, of course I remember. That's what I mentioned earlier, is that we really regret that we didn't also score the quality of life of the patients, how it improved during treatment. That was really obvious. But we also have those data now in the second, what we call the second cohort, and you see that it really improved a lot. So that's really very important to figure out as well. And the options for using Ampligen is really more than only Ampligen. It could be added to dendritic cell therapy. It could be added to the neoadjuvant program, which was actually published in the New York, England Journal of Medicine 2 or 3 weeks ago, which also looks extremely powerful and extremely, successful. And T-cell cloning expansion, it could be huge, but we need to start somewhere. And I'm really happy that I could be one of the places where we could easily start doing so.
Appreciate that. So I think for the next step and continuing on this theme, so assuming Ampligen is successful in the treatment of pancreatic cancer and does receive approval, Dr. Van Eyck, how do you see Ampligen fitting into the overall treatment paradigm for pancreatic cancer?
Well, just as I mentioned, we have already, I think, data that support how we can select our patients. And then, of course, we need to do starting up phase 2-3 clinical trials in order to really prove that it's useful. But the problem I always have by doing phase 3 studies in pancreatic cancer patients, especially with metastatic pancreatic cancer patients, is that the outcome for the control group is so poor that whenever the patients with the Ampligen will benefit a lot, then you feel really sorry for those patients who didn't receive the Ampligen. So we should figure out how to do a good study with scientific value, high scientific value, by not giving it to the patients in the control group. So that's really something I'm still wondering about. But I know that a lot of what I always call old-fashioned medical oncologists want to see phase 3 randomized controlled clinical trials. And I fully agree in breast cancer, but not, in my opinion, in pancreatic cancer, because the outcome is so poor. And I just want to give those patients something. And one thing we should also consider, although of course it's not of scientific value, is that the patients only by having any maintenance therapy do already much better than patients sending home after FOLFIRINOX and say, okay, we don't know how things are going, we cannot offer you anything, etc., etc. Those patients feel terrible. And at least in the Netherlands, a lot of patients also want to be part of these kind of clinical trials in order to improve the outcome for the next patients. That's also things you really should keep in mind. And in one way, pancreatic cancer patients are very handy to deal with from a scientific point of view, because you have the results very early. But on the other hand, it's very difficult, as I mentioned, because of the control group, which have such a poor outcome. So we are really still struggling a bit with that. But as I mentioned before, the opportunity is huge, looks amazing. So we really look forward, to do a lot of phase 2 studies and convince the society that there should be a place. But I really do think that there is a place as maintenance therapy, since we are giving all our patients now dendritic cell therapy who had an operation. I think we should also combine the Ampligen with dendritic cell therapy. But those things are, that's all future studies. So,
but at the heart of what Dr. Van Eyck is saying, the very heart of it, is that good medicine is about improving lives and saving lives. And at Ampligen, we are committed, or at AIM, we are committed, to that principle of good medicine. We want to help people with pancreatic cancer to have a better life. And we believe that good medicine equals good business ultimately.
Very helpful, Tom. And I guess one closing or one last topic I'd like to cover. So Dr. Van Eyck, you recently published an abstract at the International Hepatopancreatobiliary Association regarding the correlation between the toll-like receptors 3' and the results of Ampligen in pancreatic cancer. How do you see the future related to that correlation, and could it be important for all solid tumors?
Yeah, I think at least, and that's what we already started to do, is that at least it should be part of the normal pathology to do the immunohistochemistry screening for the toll-like receptors. Because it might be that those patients expressing a lot of toll-like 3 receptors at least do have a treatment option after having a recurrence. So that, in my opinion, should be at least considered to be also a very important trial. Because I think the staining of the toll-like receptor is what we saw in vitro, and we are studying now in mouse models, is extremely important, because it might be also that, as I mentioned, Ampligen just has a direct effect. And it could be very easy being done, because a lot of patients do have actually recurrence. 90%, 95% of pancreatic cancer patients after surgery have recurrence. So it can be a trial which can be very easily done.
Very, very helpful. Thank you. Really appreciate your participation in that session. Powerful information, exciting opportunities that lie ahead for AIM. So I'm going to transition before we get to the Q&A part of this session. Tom, it's clear that Ampligen has significant potential in the treatment of pancreatic cancer, but this is just one of many active programs you have. Are there any other studies investors should keep an eye on?
Oh, yes, absolutely. Of course, as I said, our top priority is Ampligen for pancreatic cancer, but not far behind is Ampligen as a therapy in advanced recurrent ovarian cancer. Advanced recurrent ovarian cancer is another one of those lethal malignancies that at that stage is basically a death sentence. There are very few options and very few chances for people that receive that diagnosis. And we have been, and we're very grateful to be a part of a study that's going on at the University of Pittsburgh in advanced recurrent ovarian cancer, where Ampligen with the cisplatin therapy is being combined with the Merck drug pembrolizumab, commonly known as Keytruda. And this study is a phase 2 study that's ongoing, and it's being funded by a Merck grant. It's a 45 subject study, phase 2, conducted with Dr. Bob Edwards as the principal investigator. Interim results from that study were published in an abstract at the American Association of Cancer Research just recently. And those data were extremely powerful, suggesting that the combination therapy, including Ampligen, had a major therapeutic impact. Now, these are preliminary data. I believe it was 17 subjects, but it was significant enough for Pitt to take it to AACR and for AACR to publish the abstract, which is available for everybody to read. And I would ask people, when they look at that ovarian cancer data, we have the benefit of seeing the Merck data with Keytruda alone in Keynote study called Keynote 100. So you can compare overall survival in complete responses, partial responses, things like that between those two studies. And you see that Ampligen is suggesting a dramatic potential. Now we have to wait until the study's completed to draw any formal conclusions, but the data that was published, is very powerful and suggests potential for a statistically significant impact in advanced recurrent ovarian cancer. So that's our number 2 priority.
Wonderful. Thank you, Tom. We are running out of time. I do want to be able to get at least a question in from the Q&A. So I'm going to transition now to and open it up for the Q&A for today's call. I see several questions have been already submitted. If we are unable to get to your question, which it does not seem likely, just given the time, we will respond to all of the questions that do come in. So our question, before we run out of time, so when do you expect to see results from the phase 2 study in pancreatic cancer?
That for Casper or for me?
That would be for you.
We can't say exactly when we'll see results. The results will be published at the end of the phase 2 study, obviously, and everybody will see those. That's going to be publicly available. However, given the suggestion that we have from the pilot data that's come out of Erasmus, we may have the opportunity to see interim results at some point in the course of this study. And if the interim results, similar to the phase 2 in advanced recurrent ovarian cancer being conducted at the University of Pittsburgh, if those interim results in our pancreatic cancer phase 2 study are compelling, powerful, and statistically significant, I trust that based upon the good clinical judgment of Dr. Van Eyck and Dr. Kloot at Buffett Cancer Center, if they feel it warrants a publication of an interim report, we, of course, at AIM would have no objection to that.
Appreciate that, Tom, we are out of time. Appreciate the audience, excellent participation, a lot of great questions that came in. We will get back to everyone that has submitted a question. This does conclude the virtual investor session for today. Before we leave, Dr. Van Eyck, any closing remarks?
No, I think it was a brilliant meeting, and I hope that I've convinced that this really looks very convincing, and we look forward to see the results over about 6 months' time, and then we can finalize our study, and then we hope to start really very fast the next study.
Appreciate that, and so much appreciate your participation. We know that you have a lot going on. As Tom had mentioned, you are a preeminent leader in this space, and we are grateful for your time today. Tom, for 1 minute, any closing remarks you'd like to make?
Well, I want to first express my appreciation for Dr. Van Eyck, his team, Erasmus Medical Center, and also to the government of the Netherlands. Without the forward-thinking and aggressive, intelligent insights exercised by the health inspectorate in the Netherlands, we wouldn't be where we are today, seeing these positive data. So I'm very grateful for the Netherlands and the opportunity they've given us. And I also want to say thank you to you, Janine, for this wonderful program and this forum, giving us an opportunity to discuss what we're doing and why we're doing it.
My pleasure, Tom. What a great session. So much information, so much hope, as you had mentioned, for patients, not only in pancreatic cancer, but as we can see, there's a lot of utility with Ampligen. And so a lot of other cancers and other diseases that can be helped. Tom, thank you. Dr. Van Eyck, thank you. Dr. McClear, so grateful for your time today. A great session. This does conclude AIM's presentation. I'd like to thank everyone for joining us today, our audience, especially for the thoughtful questions, for your participation in our Spotlight series. Again, you can reference our webcast replay at virtualinvestorgo.com. As a reminder, AIM is listed on the New York Stock Exchange under the ticker AIM. Look forward to getting updates, Tom, on AIM in the future. And thanks, everyone. Have a wonderful day.